Hi guys, welcome back. I'm Zoe, I'm a foundation dentist working here in London.
And I'm Ali, a final year dental student studying at Newcastle.
In this part of the educational series, we're going to show you how to turn all the information from your history and examination into a well-structured treatment plan that you can follow.
This video will follow the order which we think you should write your treatment plan, and there's timestamps on screen and in the description if you want to skip around. The order to follow in treatment planning is the acute phase, prevention, stabilization, definitive treatment, and finally maintenance. We've taken and adapted a lot of the content from this video from a book called Diagnosis and Treatment Planning in Dentistry, and we recommend you check it out. Your uni might name things slightly differently, so just bear that in mind, and as you watch this video, it will all make sense.
The first phase of any treatment plan should be the acute phase, where you basically get the patient out of pain and you address any emergency or urgent problems they might have. So some problems may need immediate attention and you will need to treat them on the same day. And these are emergency problems like severe dental pain or swelling or systemic infections or trauma to the face or the jaw.
Whereas some problems don't need immediate attention, but you or the patient think they should be attended to now or soon. And these are the urgent problems like mild to moderate pain without active infection, asymptomatic broken tooth, lost restorations, and other purely aesthetic problems like a small enamel fracture of the upper right one. These are treatments which postponing won't cause the patient any unnecessary pain or risk of systemic illness, for example.
This part of the treatment plan is often overlooked because when we're treatment planning, we tend to start thinking about all the different restorative or perio problems, but the acute phase is especially important when it comes to building a good rapport with your patients. Sometimes patients will come to your practice or your hospital because they have no choice because they're in pain. They might have been kept up by the pain and be really moody and maybe fearful because they don't know what treatment that they might need.
Now, if you take a nice empathetic approach, find out which treatments are emergency or urgent, and you get them out of pain or fix their broken tooth, then you might have just turned that anxious patient who would only have come in for the emergency into someone who's willing to come back to the hospital or the practice for completing the rest of the treatment plan. This can be a massive way of attracting new patients to the practice and can help dental students get patients coming back so they can get their totals done.
There's loads of different emergency and acute problems and we're not going to bore you by going through all of them in this video, but there's a table for you guys in the document in the description listing out all the most common acute problems and some treatment options for the short term and their long term implications. So check out the link in the description.
After the acute phase of the treatment plan, you need to look at prevention. Prevention needs to be in nearly all treatment plans that you write. It should include oral hygiene instructions, fluoride, and diet diary and advice. There's a Public Health England document called Delivering Better Oral Health, and every dentist and every dental student needs to have read this at some point. It covers everything you need to know for prevention, and you can find it in a link in the description.
In the modern age of dentistry, we want to move away from having to constantly treat caries to focusing on preventing caries from happening in the first place. This is why prevention comes before stabilization or definitive treatment. You don't want to start doing any perio treatment or fillings if the patient is still not brushing their teeth properly or using the correct toothpaste because your perio treatment or filling might actually fail. So get it in as early as possible, ideally in the first appointment. The next phase is the stabilization phase and is kind of connected to prevention in the sense that we want to stabilize their dentition to prevent any of their current diseases from getting worse. The only time you don't need a stabilization phase is in a diseased patient when the definitive treatment phase will eliminate the diseases anyways, like a full mouth clearance on someone who has carious teeth who needs an upper-lower complete denture, so there would be no point in filling all the teeth in.
The main sections you want to stabilize are caries, perio, pulpal or periapical, and extractions of hopeless teeth with immediate gap replacement, if needed. Now, if your patient requires all of those things, you can't just do them all at the same time because let's say you just do perio, then the caries might advance further. This is where the difficult part of treatment planning comes in, and we'll explain later how you can handle this. But for now, let's explain each section in the order in which you should write them in your treatment plan, so you have a better understanding of what they include, and then we'll explain how to manage multiple sections at the same time.
So the first section to mention is perio, and the main thing you want to look for when writing out your perio treatment is the patient's BPE. If your patient's BPEs is 0s and 1s, they don't have periodontal disease, and the treatment is covered by the oral hygiene instructions you would have given in your prevention stage. But you will still need to consider the risk factors for having periodontal diseases in the future. There's a whole list of risk factors, but the main ones are smoking, alcohol, and diabetes. You need to assess and manage these risk factors for all patients, not just the ones with BPEs of 0s and 1s.
If your patient's highest BPE score is a 2, you would need to write remove plaque retentive factors and note down their locations if it's an overhanging restoration or a ledge, but you don't need to note down every tooth that has calculus because you would remove all the calculus when you do a supragingival scale.
Now, if your patient's highest BP score is a 3, you need to write initial periodontal therapy, including supragingival scale, oral hygiene instructions, and a review 8 to 12 weeks. You could stop there, and to be honest, most people do, but ideally in your treatment plan, you should also know what happens at the review. So you could add, at review, if BPE remains 3 or 4, carry out 6-point pocket chart and RSD of pockets larger or equal to 4 millimeters under local anesthetic, once oral hygiene is adequate, plus 3 months review.
If your patient's highest BPE score is a 4, you should write 6-point pocket chart plus RSD pockets more than or equal to 4 millimeters under local anesthetic once oral hygiene is adequate, plus 3-month review. I know this sounds really long, but you can use abbreviations and it will be much faster to write on clinic. The reason you do perio before you do any definitive treatment is because there's no point putting in some beautiful crowns and then later down the line the patient doesn't clean the margins and the perio gets worse. At the same time, you need to use some common sense of what is achievable for a particular patient. If someone's oral hygiene won't improve more than its current status, maybe because they have arthritis in their hands for example, then you should continue on with your treatment but possibly consider a less damaging option.
The next section to include is checking uncertain teeth. Look at your chart and ask yourself, are there any teeth which we're unsure of their restorability? These are teeth which would have to investigate further by removing caries and then assessing the options. Options might be a filling, root canal treatment and a crown, or an extraction if you find that the tooth is completely unrestorable. But you will only find this out after you've removed all of the caries and you can see the extent of it. You can explain all of this to your patient and let them know of the plan.
Next up is caries. You have to look at the chart and ask yourself which teeth have caries. On one tooth, it might have just started and be really early stages which has become a white spot lesion. It could have become cavitated and be just into enamel or just into dentine. Or it could be deep into dentine and be encroaching on the pulp. Each of these require different treatments and you need to know which would be the most appropriate treatment, and this is based on the extent of the caries.
Now, if you see a non-cavitated carious lesion, you would just treat that by applying fluoride varnish and monitor it to make sure it's not getting any worse. However, if it was a larger carious lesion into dentine, you would need to drill away the caries and fill it in. At this stage, you need to decide what you will fill it in with, and this can be a temporary material like GIC or resin modified GIC, or a more mid to long term material like composite or amalgam.
If the patient has lots of caries, you want to stabilize them as soon as possible, so you can choose to stabilize them with a temporary filling material like GIC because you can stabilize all the caries quicker in fewer appointments. In that case, in your treatment plan, you would write stabilize with GIC and note down which teeth. Trying to fill all those teeth with composite and amalgam would take too long, and in that time, the caries might get much worse. And then suddenly one tooth might need a root canal treatment, for example.
However, if the patient doesn't have a lot of caries and it's only a few teeth, you can place a mid to long term restoration like composite or amalgam. So in your notes, you could write direct restoration and note which teeth.
Next on the list is pulpal and periapical tissues. This is where you need to look at the chart and radiographs and see which teeth need the root canal treatments. For example, on your chart you might have seen carious lower right 6, and on your radiograph a big apical radiolucency, and the tooth was non-responsive to sensibility testing. All of this points to the need for a root canal treatment. In your treatment plan, you would write upper right 6 root canal treatment or XLA, and then explain the two treatment options to the patient and decide which they want.
Next up is planning for extractions of hopeless teeth, and this might be a retained root or a grade 3 mobile tooth with over 90% bone loss. And lastly, you want to provide temporary solutions to any gaps that they might have. This could be because they have a missing upper central incisor, or they struggle to eat because they don't have enough teeth in the arch. These kind of problems can be temporarily fixed with denture additions to an existing denture, or if they don't have a denture, asking your lab to make a temporary partial denture.
So now we've covered all the sections of stabilization, and there were quite a few. So how do you actually carry out all of this, and which ones do you do first? One way of doing this is by carrying out quadrant dentistry. And this is where you look at all the stabilization that is needed and you do it 1 or 2 quadrants at a time per appointment.
Now you might think, well, which quadrant shall I start with? And that's where you can decide as a dentist by prioritizing which section needs to be attended to sooner rather than later. In general, treatment of deep carious lesions in vital teeth, symptomatic pulpal problems, and acute oral infections take precedence.
For example, let's say you have a patient who has perio and also needs a filling and an extraction of a retained root. Out of all of these, the main one that can be a problem if left untreated would be caries. If you have a tooth that has deep caries, then you should prioritize the quadrant with that tooth, because if you leave it for too long, the caries might reach the pulp and the tooth might then need a root canal treatment. So you start in that quadrant, and in that appointment you can do all the fillings in that quadrant and carry out RSD in the deep pockets. The next appointment you pick the second worst quadrant and then you do the same.
And as you're carrying out the perio and the fillings, you can talk to the oral surgery department to plan a date for the extraction of that retained root. Once you have a date for the extraction, you can talk to the prosthodontic lab to have an immediate denture ready to be fitted after the extraction.
You can see how multiple sections of stabilization are handled at the same time to ensure they happen in as few appointments as possible, in a way that you don't neglect any section. The key is to prioritize and see which tooth needs attending to first, and start with that quadrant.
The next phase of the treatment plan is the definitive phase, or as others might call it, the restorative phase. In this phase, you're looking to carry out any direct restorations which might have previously been stabilized with GIC, any indirect restorations like onlays or crowns, and you'll also treat any missing spaces with bridges, dentures, or implants.
So let's start with direct restorations, and the main ones are composite, amalgam, and GIC. Composites were first made to be used as anterior fillings, but since they've gotten better and better each year, they're now used as posterior fillings as well, especially outside of the UK. But under the NHS, the first go-to material for posterior fillings would still be amalgam. However, at your uni, you might be given the flexibility to use amalgam or composite, and we usually use composite just to practice. But it's also important to use amalgam.
Amalgams are good in posterior fillings because they're stronger and more resistant to fracture, and the studies actually show that they tend to last longer than composites. Now, let's say there's no NHS limiting your choice of material. What do you use for a posterior filling? Let's go through some things that you should consider. One of the main factors is patient preference. No matter how much you tell the patient of all the advantages of amalgam and that the risk factor to mercury is actually quite low, if they don't want a silver filling, or to be fair, they have a metal allergy, then the choice has been made. You use composite.
If the patient doesn't mind having a silver filling, then you need to see how big the cavity is. If the cavity is quite small, then you're going to struggle getting retention with amalgam, so your best bet would be composite. If you have a larger cavity to fill, and maybe even a cusp to replace, then you might want to think about amalgam. However, saying that, composites are getting better and better, and many dentists will argue that composites are just as strong and even better than amalgam, so you can use composites for even larger restorations.
Now moving on to indirect restorations, we have inlays, onlays, and crowns. Indirect restorations are lab made and need to be bonded or cemented to the tooth. The first one is inlays, which just covers the pits and fissures, and to be honest, we rarely do them. The idea is that they're more resistant to abrasion and occlusal wear compared to doing a direct composite, but they're more expensive, they require more chair time from the patient, multiple appointments, and they're quite fiddly to bond to the tooth because they're so small.
Now, onlays on the other hand have a lot more use. They basically cover one or more cusps of the posterior teeth, and in the book, the official definition is that it covers up to 5/8 of the tooth, and any more than that would be a crown.
Onlays are a more minimally invasive option to crowns and are used to provide cuspal coverage to strengthen the tooth, for example, if it has a crack or after root canal treatment. They're better than doing a direct composite because a lab-made onlay will be stronger and have better contours and contacts. Sometimes, however, there's so much tooth structure that has been lost from caries, for example, that your only option would be to do a crown. Here we talked a bit about each of the options, but check the link in the description for the document where we have a table for the treatment options of the main tooth conditions.
Now, after indirect restorations, you need to look at replacing any gaps. The typical options are bridges, dentures, or implants. Which one you go for here massively depends on budget, size of the gap, and patient preference. Bridges can be a great option for smaller gaps, dentures can be a great option for larger gaps, and implants can be a great option if the patient can afford them. Again, there's a table in the document in the description which lays out all the different treatment options for different gaps.
So how do you write all of this in your treatment plan? Well, if there are multiple restorative treatments, you can use grids and list them out. Start with direct restorations, write all of the teeth that you plan to fill and maybe annotate with materials you plan to use. Then note indirect restorations and annotate what the indirect restorations will be. And finally, any gap replacements and again, what the gap replacements you plan to put in.
So after the definitive phase comes the maintenance phase, where you'll see the patient in regular intervals to monitor their oral health and to prevent any disease like caries from happening. The general advice is to have checkups with your patients every 6 months, but you might need to see them more frequently if they are a perio patient or if you feel like they haven't fixed their diet or their oral hygiene regime. In those cases, you might choose to review them every 3 months. This kind of thing changes case by case and is usually up to the dentist to look at the patient as a whole and decide how often the patient needs to be seen.
In these appointments, you're looking at recharting, reinforcing oral hygiene instructions, giving diet advice, represcribing fluoride toothpaste, rechecking BPE, or redoing 6-point pocket charts, giving a scale and polish if they need it, and taking updated bite wings according to the FGDP guidelines. You'll also need to monitor anything else that you might have noted previously. For example, if there was a tooth where you were unsure if it has caries or not, you'll need to check that every appointment and document it.
Thanks for making it this far, guys. We hope you found this video useful, and if you did, we'd really appreciate it if you hit the like button and subscribed.
You might also enjoy some of our other videos that we have on the channel, so feel free to check out some of the suggestions here.
If your uni teaches you treatment planning any differently, then we'd love to learn about it, so throw it in the comment section below, and we'll see you next Thursday.